Welcome back, everybody. In this episode, we're going to be discussing a paper that looks at low-dose atropine effects on binocular vision. I'm Dr. Mika, and our guest expert for this episode is Dr. Debora Chen, who is an associate professor of clinical optometry and vision science at the Herbert Wertheim School of Optometry and Vision Science. Welcome, Deb.
Hi, thanks for having me.
So the title of this article is Effect of Low-Dose Atropine on Binocular Vision and Accommodation in Children Aged 6 to 17 Years by Brilliant and his colleagues, published in the Academy's Journal Optometry and Vision Science. So the use of low-dose atropine is becoming more prevalent in optometry and primary care, really, for myopia control, although the best dose of atropine is still up for debate. And can you tell us a little bit about what this study focused on?
Yeah, so this study looked at 46 kids, so again, kind of ages 6 to 17 years old, the prime time that we think of myopia management. And there were 4 groups. So these 46 kids were divided into 4 groups. There was a placebo, and then 3 different concentrations of atropine, 0.01%, 0.03%, and 0.05%. And they measured a lot of things. They measured visual acuity at distance and near, pupil size and photopic and scotopic conditions, dissociated phoria, near point of convergence, and actually quite a few metrics kind of around that, negative and positive fusional vergence, so divergence and convergence ranges, accommodative amplitude, as well as lag of accommodation. And then all of these things were measured at several different time points. So at baseline, 30 minutes after installation, 60 minutes, and then 24 hours after installation or application.
That's a lot of data points.
There's a lot of data points.
Okay. So let's break this down. We'll talk about pupil sizes first. Tell me the pupils were bigger, right?
Yes. So the pupil size was significantly different or enlarged compared to placebo for the 0.03% and 0.05%. And this was both under scotopic and photopic conditions. And they kind of within that found that the biggest change from baseline was at 60 minutes. So 1 hour after they put the drops in is where they saw the biggest change in pupil size.
So it makes sense that we ask people to do this at bedtime. What were some other findings that kind of stuck out?
So, one of the things that did stick out was that the acuity, both at distance and near, as well as the accommodative metrics. So the amplitude and the lag were actually about the same across all of the groups. And that's a little different than what has been found in other studies. And, anecdotally, I'll also mention, because I see a lot of patients that are on atropine and also on vision therapy, and maybe we're training accommodation. That's kind of been a question. It's like, oh, if you're on atropine, is that going to mess up what we're doing in therapy, or how does the accommodation affect? And they found that actually amplitude and lag were not affected by these concentrations. There's a few other small differences. For example, in the break point for divergence in 0.03%, and atropine was a little bit different than it was in the other groups, but nothing that would necessarily cause a patient to say, oh, I have symptoms difference from using one concentration over the other. I'm going through all the data to see if there's anything else. But I think those were the main things that that kind of stuck out to me across all of the different areas that they found.
So these authors are concluding that any of these concentrations are safe for use in patients as far as BV is concerned. But were there any limitations to this study?
Yeah, so I think one of the biggest limitations was just the sample size. It's, given that there was a small sample size and then, only 46 patients and then kind of divide by 4, there's really not a lot of people per group. So you can imagine that there may be, any amount of variability can impact your findings one way or another. They also excluded patients, and I get it, they excluded patients with some more significant binocular vision issues. So anyone with a strabismus, amblyopia, history of strabismus surgery, vision therapy, most of their patients had pretty normal BV, and at least in the population I see, and perhaps the ones that people may be interested in, you might be wondering, like, well, if I have a patient with a BV issue and I put them on myopia management with atropine, how does it impact their BV problem? Does it make it, does it impact it at all? Does it make it better, worse? Or if I'm in active treatment for that, how do they go together? And then, they did mention safety. And I guess my thought is that the definition of safety and what it means can vary
Yeah.
depending on your interpretation and what safe means to you. So, perhaps it is safe in the ways that it did not impact the areas that they were looking at, acuity versus accommodation functions. But you kind of wonder, well, what else can we say about safety that maybe is not part of those areas too? So,
Yeah, one thing that I noted too was the authors point out that they did not control for iris color, and that's interesting to me, just knowing the mechanism of this
Mhm.
drug, and also because that seems to be something that's being looked at more carefully in myopia control. So more to come on that, perhaps. But do you have any other comments about the study, things that you wanted to mention?
Yeah, I think one of the things, if you go back, they looked at baseline 30 minutes, 60 minutes, and 24 hours. But the authors also mentioned that they didn't check at 12 hours. And I think you had also mentioned maybe a few minutes ago that, oh, maybe, because of the side effects, maybe this is why I dose at night. So wouldn't a 12-hour check actually also be really helpful too, rather than 24? So I think a 12-hour check would have been really helpful, and would probably have buttressed their study a little bit more. Um, you know, Maybe using a qualified survey, something like a convergence insufficiency symptom survey. That's probably one of the better known ones, or CISS survey, just to see if symptoms also aligned with the lack of signs and change or lack in signs that they saw. And they also noticed a big variability in phoria. So they did mention they measured dissociated phoria. And at each time point, sometimes the plus or minus was up to 10 to 13 prism diopters, which is kind of a lot.
Yeah.
Even in patients who are in theory binocularly normal, that's a big range. So I would also wonder if there were other areas around binocular instability that may be worth looking at as well.
Great. Well, thank you, Dr. Chen, for joining me today.
Thank you.